Dear colleagues, Dr. Agrawal, I would like to really thank you for inviting me to give a presentation to such a distinguished audience. So I'm originally from China, but in 1988, about 30 some years ago, I came to NIH Bethesda, Maryland for basic research for 6 years. And I later then attained University of Michigan and residency at Yale, and then fellowship MD Anderson, and after MD Anderson, at the age of 40, I got my first job ever after 40 years of training, and then I stayed on the faculty until now. So my life experience is very simple. Today, I'd like to share novel therapies for mantle cell lymphoma post to ASH 2020. I have to confess that this is mainly the studies data from my group, and there's other excellent presentations that due to the limit of time that I was not able to put it here. But this slide deck contains all the data on targeted therapies, on bispecific antibody conjugate, and also CAR T cells. So you will realize that this is actually a pretty comprehensive overall picture of the ASH meeting on mantle cell lymphoma.
Sorry to interrupt you, Dr. Wang. We can't see your slide. Can you?
You cannot see my slides?
Yes.
Okay.
You need to share the screen.
Okay, so let me see here. Share screen. Share screen. Can you see it now? Share. Can you see it now?
Yes.
Okay.
Yeah.
So I was on the first slide. So here are my disclosures. The first abstract is the window clinical trial. The Ibrutinib with the Rituximab and short course of hypercvad is very efficacious in previously untreated mantle cell lymphoma young patients. So before everybody know, the standard therapy for newly diagnosed young patients with mantle cell lymphoma, their age is less than 65 years old. There are two mainstays of therapy. One is the Nordic therapy that requires 6 cycles of induction chemotherapy followed by autologous stem cell transplant. MD Anderson does hypercvad without autologous stem cell transplant. Hypercvad, as you know, is about 6 to 8 cycles. And so both the Nordic therapy with after auto and the hypercvad 6 to 8 cycles are very toxic. Not only they have acute chronic toxicities, but also they have long-term secondary malignancies that's up to 15 to 20%. That's after 15 years of follow-up. If you follow up any longer, the secondary malignancy will increase even further. In order to reduce chemo, in order to take advantage of the powerful combination of Rituximab and Ibrutinib, and to reduce chemotherapy, we designed the window study where in part A, chemo-free window with Rituximab Ibrutinib, as soon as the patient achieves the CR, we will have 4 cycles of hypercvad instead of 8 cycles. But the patient in part A, the chemo-free portion, the window of opportunity, they have up to 12 months, but they could easily achieve a CR at around 6 months. They can go to the second part chemotherapy. As you can see, we have 131 patients, and this is so the chemo-free Rituximab Ibrutinib section before the chemo consolidation. So chemo-free therapy alone induced the response rate of 100% in 131 patients. The CR was 80%. So after 4 cycles of hypercvad consolidation, the response remains at 100%, and the CR rate rose up to 98%. MRD by flow cytometry is 74, and we are publishing this with next generation MRD likely early next year. After about 4 years of a follow-up, the median survival, failure-free survival, overall survival has not been reached for any cohort by any risk factors analysis. Especially no difference in responses by Ki-7 or MIPI category. You can see after about 3.5 years, almost 4 years, the failure-free survival, overall survival has not reached the median. So the follow-up is 40 months. So side effects, as you can see, the chemo-free portion, grade 3 or 4, the side effect is not much, but the grade 3 or 4 toxicity in the chemotherapy has also is typical of chemotherapy population. In conclusion, chemo-free Rituximab induced unprecedented efficacy before chemo consolidation. High-risk mantle cell lymphoma patient had propensity to progress. Adverse event profile was very favorable. Long-term follow-up would provide even more on durability. Further studies, MRD, are underway. So that, we used Ibrutinib for many years now. That this is the previous abstract is the usage of Ibrutinib in the front line in younger patients, so less than 65. How about the elderly patients? Elderly patients, we use Ibrutinib, Rituximab without chemotherapy, and because the elderly patient, they could not tolerate the 4-cycle hypercvad that well. And this is presented by my mentee and my good friend Pritish Jain, who has just joined our faculty as of July of 2020 during this pandemic year. Dr. Pritish Jain is a very brilliant, talented researcher and is extremely knowledgeable. And I really think he is my protege, and I think he's joining our faculty will bring even more success to our program. So he and I studied the frontline therapy. As you can see, in elderly patient, you do the Rituximab, Ibrutinib, the overall response rate is 90%. The CR rate is as high as 62%, and PR is 28%. MRD 87%. After about 43 months of follow-up, the failure-free survival, overall survival has not been reached. So here the curves you can see easily. So the side effect actually is pretty much significant. As you can see, the biggest problem is atrial fibrillation. Basically, grade 1 or 2 in 10% and grade 3 or 4 in 22%. That is a very big number for atrial fibrillation. We think that anybody received Ibrutinib long enough would have cardiac arrhythmia problems. And therefore, in clinical trials, we would exclude this patient with 3 or more EKG changes, or they have any kind of a deviation axis, RBBB, especially LBBB, they should be excluded. And if they have any cardiac dilatation on the echocardiogram, chamber dilatations or thickness, or any echo problems, or if echo is less than 50, they should not be treated with Ibrutinib, especially in the front line. But this clinical trial was designed 5 years ago. At that time, the Ibrutinib was used not so long. The atrial fibrillation was not that a big problem. So we did not exclude this patient. And this is exactly why the atrial fibrillation happened. We have 20% of patients who have prior atrial fibrillation intermittently, who was in sinus rhythm at the beginning of the enrollment. We still included them. And those people has frequent relapses of the atrial fibrillation. So in conclusion, Ibrutinib Rituximab combination is highly effective, easily given chemo-free therapy option for transplant ineligible elderly patients with non-blastoid. Please remember, those people who enrolled in this trial, their Ki-7 is less than %, and they do not have pleomorphic or blastoid variant. The increased incidence of arrhythmia observed in our study is likely due to high number of cardiovascular risk factors in the population. This suggests that baseline cardiac evaluation and cardiovascular risk factor modification should be added to the frontline therapy. So switching gears, the simpatico study, and we also presented by Dr. Kontam, senior authored by myself, is on the ibrutinib venetoclax combination. And this combination is the simpatico study has 3 parts. The first part is a dose escalation study in the dose finding part. The second part is a massive 250 patients international randomized study with ibrutinib plus venetoclax and versus ibrutinib plus placebo. So the second part data is not matured and it's not published and presented yet. The third part of the ibrutinib study is this combination in frontline this time is enrolling. So this presentation at ASH is only on the first dose finding part of small portion. As you can see, this is a dose escalation scheme for all the way from 200 to 400. And you can see the side effect occurs. The most common is diarrhea and fatigue and nausea. And there's almost a lack of, if you do not count the general fatigue, diarrhea, neutropenia, cytopenias, there's a lack of grade 3 or 4 toxicities, and as you show orange. So there is grade 3 or 4 upper respiratory infections. As you can see, you know that ibrutinib and other BTK inhibitors are associated with increased infection. So data summary in this very small study with 21 patients. So the 22 patients, the overall response rate, including all the population, is 81%, and the CR rate is 62%. Please remember, I just presented you and Dr. Prithjing and I study the RI study with rituximab ibrutinib in elderly population. The overall response rate is 90%, the CR rate is 60%. So please take in consideration that both the rituximab ibrutinib and the ibrutinib venetoclax combinations are both very powerful. So failure-free survival has not been reached after a good follow-up period of time. At this ASH, I also presented Loxo 305, a next generation highly successful non-covalent BTK inhibitor in previously treated mantle cell lymphoma, Waldenstrom's, and other lymphomas. Please remember, as you all know, the first generation of BTK is ibrutinib. The second generation is acalabrutinib, the new ibrutinib, and the newly presented orelabrutinib. They are all first and second generation. They all attacking the same site at C481. But Loxo 305 attacks the ATP binding site of the BTK protein, therefore differs from the previous first and second generations. Loxo 305 represents the first in class of the third generation. Both the first and the second generation, they are irreversible and covalent binders. In contrast, Loxo 305 is reversible and non-covalent. As you can see, mantle cell lymphoma 61 patient, Waldenstrom's 26 patient, and other lymphoma 66%. Please remember, the median prior lines of therapy was 3 for mantle, 3 for WM, and 4 for other mantle cell lymphoma, for other lymphomas other than MCL and WM. As you can see, the grade 3 or 4 toxicities are very rare on the Loxo, so this is basically we escalate the dosage in the study. There's no DLTs. 323 patients was included in the study. Only about 1.5 patients discontinued the therapy due to AEs. And 200 milligrams every day orally, once a day drug is used for further studies. As you can see in the phase 2 cohort, including 56 patients, the overall response rate is 52%. However, 93% of this population received prior BTK inhibitors, first and second generation, and their response rate remains at 52%. As you can see, although only 52% meet the cutoff of partial response, but the majority of our patients benefited the therapy in this waterfall plot. And you can see some of the earliest patients was in continuous CR as shown in blue and or gray as you can see it, and the orange representing PR. So it has been quite durable, although the median follow-up period is still low at 6 months. The efficacy of LOXO-305 in Waldenstrom's among 19 evaluated patients, overall response rate is 68%. And this is very, very significant. If the patient did not receive the prior BTK, if the patient received the prior BTK, the number is 13%, the response remains very high at 69%. As you can see in the waterfall plot, majority of the patients benefited even after 3 prior lines of therapy for Waldenstrom's. Here's the data for the other lymphomas. Please remember, this is the fifth line therapy after 4 prior therapies for all the lymphomas. As you can see, Richter's transformation, 75% response rate, although only 8 patients. Follicular lymphoma, 80 patients, 50% response rate. Marginal zone lymphoma, 9 patients with a 22% overall response. Large cell lymphoma, as many as 25 patients. Overall response 24%. For each category, there's long durability patients in remission. In conclusion, LOXO-305 is a promising drug in mantle cell lymphoma and other lymphomas. It has a favorable safety and tolerability and durability profile. So the next exciting abstract that is VOS-101. This is ROR1 targeting antibody and drug conjugate. In this abstract, it demonstrated predictable safety profile and clinical efficacy in lymphomas, especially in mantle cell lymphoma, large cell lymphoma. So ROR1 is an oncofetal protein used that appears on the cell surface in the embryonic development phase. This antigen typically disappears after birth, but it reappears if there's a malignant transformation of solid tumors or liquid tumors, and including lymphoma. As you can see, this ROR1 antibody is a cell surface protein that rapidly internalized into the inside of the cell once upon binding. Please see there's various levels of expression, and there's also expression in CLL, as you can see, is pretty high with the median about over 80%. So in this phase 1 clinical trial, please remember so far the 2 circles in mantle cell lymphoma and about 60%, and large cell lymphoma about 50% expression, far less than CLL, which is over 80%. As you can see, the VOS-101 had 3 parts. First, it has an antibody called UC981, it's a monoclonal antibody against ROR1 protein, and it has a proteolytic linker, and also it has the warhead MMAE, monomethyl auristatin E, the same toxin we used in Rituximab vedotin. As you can see, once upon binding to the ROR1 on the surface on the right, the graph, it rapidly internalized and transporting this drug into the lysosomes where the enzyme would open the linker, releasing the toxin, which in turn kill the cells. This is a dose escalation first in human study. Please remember, the LOXO-301 I presented previously, this was on a first in human study. This study is also first in human. It is hard to imagine these two outstanding clinical trials. They are both first in human. They almost hit the home run in the phase 1 part, not only in safety, but also in efficacy. So in this clinical trial, there are 32 patients, and you can see the prior median numbers of prior therapy was 4. Please remember, this is a very previously heavily treated population at the 5th line. The side effect attributed to this drug is mainly due to the MMAE, the warhead. It includes neutropenia, neuropathy, rare diarrhea, and extremely rare alopecia. Regarding the normal tissue, because ROR1 is not present in the normal tissue, unlike CD19, which present in both normal and tumor tissues, ROR1 only in malignant tissue, therefore, there's no infusion reactions with a total 166 infusions. There's no venous irritation, not a vesicant. Although we do not use pre-medication for nausea vomiting, there is rarely nausea vomiting. No tumor lysis, no evidence of ocular, skin, cardiac, pulmonary, hepatic, renal, metabolic toxicities, no drug or exposure-related cardiac QT prolongation, no clinically consequential immunogenicity. So as you can see, at the 5th line therapy, the mantle cell lymphoma response is 47%. Everybody in the audience, in this very disclaimer audience, know that the natural history of hematologic malignancies are repeated remission, relapse, repeating relapse. After 4 to 5 prior relapses, with each relapse, the efficacy drops by 15%, and the resistance goes up until after 10 to 20 cycles, the efficacy drops to 0 because resistance increases to 100%. After 4 lines per therapy, the overall response rate in mantle cell lymphoma was 47%. If after 4 cycles, I think it should be exceeding 62%. And so 47% in the 5th line, and the 5th line for large cell lymphoma, only again 5 patients, 4 of them responded for a response rate of 80%. Here is a 63-year-old gentleman with a double hit high-grade large cell lymphoma. He has received 4 prior systemic therapies, including CAR T cells. And so after CAR T cells, unfortunately, he relapsed quickly, but also proven recurrent high-grade double hit large cell lymphoma in lymphadenopathies and also in skin. He had so much skin involvement on the right leg, so the right leg was amputated below the right knee because in fear of further aggressive relapse, including invasion into the bones. So after the amputation, you can still see lymphomas everywhere on the skin and possibly in the bone as well. But at the end of the 3rd cycle of VOS, which is a weekly infusion for every 3 weeks, so you can see the VOS cleared the lymphoma into a metabolic response, complete response. The patient stayed in metabolic response after 6 cycles, and actually stayed on further remission even beyond that. So in conclusion, VOS 101 is going to be a major player, and it's going to be a very good therapy for not only for large mantle cell lymphoma, but for other possible lymphomas. I wanted to explain to everybody that unfortunately VOS, despite the high expression in CLL, did not work at all in CLL. in my opinion, that's what a good drug behaves. Why it does the CLL patient does not respond and with a high expression level, we still don't know, and we are under the mechanistic studies underway. So at this ASH 2020, I also shared the one longer follow-up of ZUMA-2 clinical trial with a median follow-up of 17.5 months. Please remember, at last ASH, I presented the initial presentation, it was 12.1 months. And after the ASH presentation, the data was published in New England Journal of Medicine on April 1st of this year. And the FDA approved this therapy on July 24th. This is a 17.5 months follow-up. The CR rate stays as high as 92%, and the overall response rate stayed as high as 92%, and the CR at 67%, almost no change from the presentation. The first 28 patients who were treated earlier on this trial had a median follow-up of 32.3 patients. 32 follow-up time and 32 months, almost approximately 3 years. 39 of these patients remain in continued remission. Here you can see the duration of response, failure-free survival, and overall survival. As you can see at the end, each one has the typical CAR T-cell therapy plateaued part, which does not mean that there will be no relapses, but the relapses are much decreased with lesser and lesser, fewer and fewer events. The side effect, basically no patient died, no CRS of grade 4 or 5 occurred during the 1 year of follow-up since ASH. The B cells recovered over time, although CAR T cell was still present in some of the patients at 24 months, but it decreased over time. In conclusion, ZUMA-2 study with a CAR T cell CD19 from Kite continued work in mantle cell lymphoma. See that here is the transient lysocell relapsed mantle cell lymphoma CAR T cell in the abstract presented by my good colleague from Memorial, Dr. Leah Palamba, with me as the senior author. Please remember this the difference between the previous CAR T cell from Kite using the co-stimulation molecule of 28, and this lysocell used the co-stimulation of 41BB. So this is the production because CD4 and CD8 was infused separately and consecutively using 1:1 ratio. The overall response rate 84%. Remember the previous one is 92%, but the CR differ. They almost do not differ. The previous it was 67. This one is 66, and this is very, very important to keep in mind that although we cannot compare trials across the board, they are both trials after 3 prior lines of therapy. They still put us into a perspective. And the severe side effect of CRS is only 9% if it's grade 3 or 4, but in the previous study was 15%. And neurotoxicity severe is only 3% compared with the previous report of 31% grade 3 or 4 neurotoxicity. And the response is durable in some of the patients, although the median follow-up is very short at 3.9 months. In summary, this is very, very good therapy with a tremendous good profile and could potentially be used as an outpatient. And this is a pivotal study. Hopefully, in the near future, this is also approved for our patient. So basic research from my lab, including quite a few abstracts. Our lab is busy with the oncogenic MOD1 and the single cell transcript technology, deciphering the resistance of BTK and CAR T cells, and the PDX-based genomic transcription pathological landscape, and also targeting R1, and investigating microenvironment, and also develop drugs of PRMT5. And the MOD1 inhibitor my lab has collaborated with a Indian biotechnology 3 or 4 years ago, and now this company has been successfully merged with the American company who will carry this MOD1 inhibitor into a clinical trial. We also studied the CDK64 inhibitors, and abemaciclib AZD is a dual BCL2 XL inhibitor, and also investigated checkpoint FC grill using monoclonal antibody BI 1206, interrogation of dysregulated pathways, overcoming CAR T-cell resistance, and targeting the checkpoint using a novel CDK9 inhibitor. That's my presentation. Thank you for listening.